Afternoon. I want to welcome everyone here to Memorial Sloan Kettering. My name is Andrew Kung. I'm the chair of the Department of Pediatrics here at Memorial Sloan Kettering, and I'm delighted to be able to welcome all of you here for this very important meeting. Together with our partners at SIOP, we're honored to host this important side event during the 80th United Nations General Assembly. Now, the theme of this year's assembly is Better Together, which really, I think, speaks to the mission that all of us here in this room share. Today, we gather with the recognition that improving outcomes for children with cancer is a challenge that no single institution and really no country alone can solve. It really requires a collective commitment, a collaboration without borders. This month, being September, we also mark Childhood Cancer Awareness Month, and we're reminded of the staggering urgency of this shared mission. Each year, nearly 400,000 children are diagnosed with cancer worldwide, and strikingly, 90% of these children reside in low and middle income countries where survival rates are far lower than in high-income countries. This really represents one of the starkest inequities in global health. And this is one that we have the responsibility and I think the power to change. I'd like to take this opportunity to thank the organizations that have made today's gathering possible. In their sponsorship, we're grateful to St. Jude Global, Foundation S, Childhood Cancer International, and the MSK Stavros Niarchos Foundation Global Pediatric Cancer Program. I'd also like to extend a special thanks to Suzanne Wohlert, the CEO of SIOP, and to my colleagues Rachel Corky and Penny Sogas from the MSK team for their planning and execution to bring this event to life. Now, to all of you joining us today in person as well as online, thank you. Your commitment and collaboration are driving a global movement to ensure that every child with cancer has the chance not only to survive, but ultimately to thrive. And so with that, we're going to change the order in the agenda up a little bit. I'd like to welcome Carlos Rodriguez Galindo, Director of St. Jude Global, to the podium for some opening remarks.
Thanks so much, Andrew. I was supposed to say a few things at the end as a closing remarks, but unfortunately we'll have to leave a little earlier. And so I thank Guillermo, Andrew, Ira, everyone organizing this for giving me this chance. I see Andre, Roberta, Sam, so many great people joining us today, but I will be very brief. A couple of days ago, we were at the United Nations General Assembly to celebrate the progress in childhood cancer and to call as well the attention that there is a long way to go, that we have done a lot. And we look back on where we were 7 years ago when the Global Initiative for Childhood Cancer was launched, and there was so much to celebrate. There's definitely so much, but there is still so much to do. Andrew, you mentioned the 200,000 children that die probably without even being diagnosed or to even being given a chance. And these are the children, that North Star that we always keep in our minds. There is so much we need to do. Each one of those children are calling us to respond, to think about them, to do something about that. So these last couple of days, we have all been reflecting a lot. We have made so much progress. On Tuesday, which day was Wednesday, we had first ladies, celebrating and calling for their countries and the first ladies of the world to unite against childhood cancer and for children with cancer. We had 30 ministries of health that wanted to speak. There was no room for everyone. And we never thought that 7 years ago that this could happen. And I thought, why did this happen? Why did we get to this point? And I think it's because of this, because that community that we have been able to build. Otherwise, without that, I don't think anything would have happened. I think that we all say that to save the life of a child, we need a village. And that's the village that we have been able to feel, where every single one of us plays a role, and every single one of us needs each other to make sure that that village protects the most vulnerable, who are the children with cancer. So for that, I'm very grateful to be part of that village. I think we have been able to build that village, and that village is where all these children with cancer in the world should feel nurtured, protected, and be given the chance of a cure and the gift of life. And so for that, I want to thank MSK, SIOP, and everyone that has been part of that, because that's how we celebrate, how we engage each other. And I hope that we can continue to that for many more years, because the work will not be done for quite a while. But thanks so much for coming here, and a pleasure to be here. Thank you very much.
Thank you so much, Carlos, for coming. Thank you for your words. I wonder if Dr. Caifones has arrived already. I know that he was a very stretched schedule, so probably he's not able to come. So I will go straight to my welcome words. SIOP warmly welcomes you to this event, and where we gather to celebrate, as Carlos said, the achievements, discuss the strategies for dealing with the remaining challenges, also and celebrate this happening for the childhood cancer worldwide. The world is changing. I think there's no doubt about it. But in our field, I think that the pace and the scale of these changes are unprecedented. Today, we are halfway through the ambitious timeline that the GICC, the Global Initiative for Childhood Cancer, established to achieve a 60% survival rate worldwide for the 6 most common cancers. The GICC, led by the WHO and St. Jude Global, with the vital support of SIOP and CCI, we are non-state actors with in official relations with the WHO, is creating a global movement to achieve this goal. So this week, I think we celebrate that. We celebrate that for the first time ever, childhood cancer is going to be included in a political declaration at the United Nations General Assembly and hopefully signed by all member states. We witnessed the commitment of many governments, as Carlos said 2 days ago, in the United Nations from different parts of the world, united by the call by Uzbekistan as the calling country for that meeting, and St. Jude. So as we know, for our global mapping program, most of the children in the world are treated in public hospitals. So the involvement and support of ministries of health and government in this endeavor is completely crucial and essential. We will hear today from Kath Lam and our colleagues what is doing with the WHO and St. Jude Global are doing to include childhood cancer in the national cancer control plans all over the world. Today, we have in this event many people that are making the world change, and we will remember for that for many generations to come of pediatric oncologists. For my generation, for the generation of many of you today, as pediatric oncologists practicing in high-income countries, these recent changes seem dramatic, but compared to what is seen in low-income countries, our advances in genomic studies, in new treatments, are really impacting very little in survival compared to the impact that the GICC is having. So these advances are almost imperceptible for us. But please pause for a moment and think about what is going on in the areas of the world where the GICC is impacting the most, where these survival rates are improving probably from 20% to 60%, and in 1 decade. This is just, probably that is just not progress. This is really a revolution that is happening around the world. So imagine the scale, imagine the thousands of children with cancer that now will survive. The new generations of pediatric oncologists in these settings should be experiencing the excitement of our pioneers like Sidney Farber, Joseph Simone, here Norma Warner. What they felt in the 70s, that they knew that children with cancer could be cured, and they saw that these children could be cured. We came afterwards. When we came, this was already happening. But in low and middle income countries where the GICC is now impacting the treatment of these children, this is really happening now. And this generation of pediatric oncologists in low and middle income countries has to be trained to find the right treatments with the right agents to be applicable in their settings with their resources and in their populations with the socioeconomical determinants of health, as we will discuss today. This is a big challenge, of course, but I know they will succeed. They will succeed. We all know they will succeed. They will be the new Sidney Farbers, the new Joseph Simones, the new Norma Warners in the world, in their generation. And they will be read and honored by all of us for a long time by curing cancer worldwide. That also needs research, and SIOP is building local capacity in cooperative groups in low and middle income countries through the PARC program, which is Program for Advancing Research Capacity that Carl Allen is leading and will be discussing today. And all of this is happening today. And we have invited also representatives from many areas of the world with different perspectives. We have here today many change makers, from specialized surgeons like Dr. Abramson to young investigators, from public health specialists to WHO officials, from psychologists to representatives of parental organizations, from Latin America to Africa to Asia and to Oceania. And that is what SIOP is all about. SIOP is a professional society for people. We are only a person can be a SIOP member, not a hospital, not an association, not a government. And we embrace that diversity and provide a setting for discussions, progress, and celebration, and collaboration and celebration. And that concept, collaboration, is a concept that now seems to be complicated around the world. So I would like to thank Memorial Sloan Kettering for hosting this event. This is an institution that is very close to my heart, where I start part of my training. Many of the things I know, I learned it here at Memorial Sloan Kettering with my mentor, Dr. Abramson, and many other friends from the very beginning of my career. I'd like to thank also the WHO, especially Roberto Ortiz, whom we grew together working in Latin America. I'd like to thanks for her wisdom and support to this event. I also like to thank Carlos and St. Jude in general, and all my friends in Memphis for all I learned, for all you are doing, and for being such a close collaborator to SIOP. I also like to acknowledge especially my predecessors at SIOP, Eric Buffet, Julia Challinor, Kathy Pritchard-Jones, for allowing me to continue their work. And it's really a big honor for me. So I also like to thank the panelists for making the time, the generous come here to New York, spend time with us, with the whole global pediatric oncology community, share their knowledge, and really for all of them that couldn't come but are joining online. So let me introduce our first panel. Let me introduce to our moderators, Regine Kebudi, who is from Istanbul University and also a close friend and also collaborator. And also she's the SIOP Secretary General, and my great friend Arya Dankel, also a Memorial Sloan Kettering professional member at SIOP, is our representative at the ARIA program and a member of the WHO committee. Now I will be silent and I will sit down and applaud you and what that you are doing. Thank you very much.
So we thank Dr. Guillermo Chantada, Dr. Andrew Krung, and Dr. Carlos Rodriguez for the welcome remarks and the introduction. And we begin our first panel. So you have already introduced us, but let's introduce ourselves before the moderating. As Guillermo said, I'm Rajin Keburi, Professor of Pediatric Hematology and Oncology at Istanbul University, Turkey, and I'm the SIOP Secretary General. And I also thank Memorial Sloan and SIOP for organizing, our partners organizing this meeting. Memorial Sloan is also important for me because when I started fellowship, I was a visiting fellow at Memorial in 1992. Norman Wallner, Jonathan Finley were here, so it's close to my heart as well. So it's very important that we are here, and we are very happy that we are here with all our collaborators and your dear guests and colleagues and friends. And I will ask Ira to introduce himself as well.
Thank you, Regine. My name is Ira Dunkel. I'm a pediatric neuro-oncologist here at Memorial Sloan Kettering, and it's a pleasure to have you all here with us today. I think, Regine, you're going to introduce our first panelist, right?
Yes. As you know, our aim in this panel is to advance the childhood cancer in low and middle income countries. And to do that, we need real data, that is strong data and with data that's reliable. And also we want to increase the workforce that is for the advancing pediatric cancer worldwide. And also we need to have our future pediatric oncologists. And now we have a panel, our very distinguished panelists. I'll introduce first our first panelist, Kath Lam. As in SIOP, we have 5 goals, the major 5 goals. That is advocacy, education, research, member engagement, and also collaboration, partnership, as Professor Guillermo Chantada has said. And the collaboration is very important. St. Jude Global is one of the very important collaborators as the WHO. And Kath Lam is from St. Jude, US, Memphis, US, and she is the director of the health systems and the WHO Collaboration Center of Childhood Cancer in St. Jude Global. Welcome, dear Kath. And so first we would like to ask you, what is the C5 tool and what is the National Cancer Control Planning integrating children, adolescents, and young adults programs? And how can this program initiate, strengthen the health strategies and also the workforce that is needed for advancing childhood cancer? And that you are doing it in the GICC focus countries and beyond, what are the key lessons that you have learned that we can use?
Thank you so much. It really is a privilege to be here with you all here in the room and with our friends Andre and Roberta online, and to be able to continue this conversation on why we have to continue to do even more to invest in childhood cancer and in children and adolescents with cancer. And both of those tools that you mentioned, C5 and NCCP ICAIA, are exactly tools to do that. They are tools to help us connect people and to expand the workforce that can enable a further expansion of the workforce. So first, C5 stands for Country Collaboration for Childhood Cancer Control. And this really stemmed from working with all of you here in the room, with the global childhood cancer community, and with our St. Jude Global Alliance of more than 400 institutions and organizations and foundations in 90 plus countries, trying to understand what are those needs of children with cancer and how can we connect it to broader needs in the health system so that it's not seen as needs of one individual hospital or one individual clinic, but that we can really connect and see a shared picture, build a shared understanding of what those needs and those opportunities are. And then thanks to friends, for instance, Liliana, helping to make sure we can implement it at a regional level with PAHO, with our friends like Joyce, to make sure that we can see what this means when we look at a national level, to really understand all the data assets. So it really means being able to have a multi-perspective lens to expand the workforce together so that when it comes to capturing needs, we can see the needs at level. And then NCCP ICAIA is really taking that at a country level and expanding it at a global level. So this week, we just graduated another 31 ministry-led teams from all 6 WHO regions in our National Cancer Control Planning Integrating Children, Adolescents, and Young Adults program. And this again started from this childhood cancer community because we heard from all of you how hard it can be to arrange even a short meeting with the ministry. And a few minutes later, it's as though those needs are buried. And it's hard to get the attention and the sustained attention of what it means to invest together in childhood cancer. So instead of that one-time, once-a-year meeting, this is really a longitudinal engagement. So we have now engaged 70 teams from 39 member states over the past 3 years, and it's a 6-month longitudinal cohort. And as a cohort, the ministry-led teams all exchange lessons learned on what does it mean to live and breathe the cure-all framework that this room knows so well. What does it mean to embed childhood cancer as part of national priorities and decision-making? And again, thanks to friends in the room, for instance, we have Natalia from Moldova. She had graduated from the NCCP ICAIA program and then brought in her expertise as someone with lived experience to help ministries understand why it's so important to have communities of lived experience as part of national policies, and that it doesn't have to be childhood cancer in isolation, but that these are policies that can also speak to the broader system's needs for children with other chronic conditions and for other non-communicable diseases. And we're so excited to see this momentum continue to grow with all of your support, because this is not a one-time policy, it's not a one-time platform, but this is really about making these living policies and making these staffed programs so that the workforce that we most need for children with cancer can actually be implemented into priorities and into budgets in functional ways for years to come.
Thank you so much, Kath. And now we'll move with another collaborator. In SIOP, we have the WHO committee, and Ira Dunkel is one of the members of the committee, and I'll give the word to you to introduce our next panelist.
Thank you, Regine. Our next panelist, Dr. Andre Ilabawi, is participating virtually. Dr. Ilabawi is the team lead for cancer at the WHO. And the two questions that have been posed to Dr. Ilabawi to address are, what have we learned from the 4th UN high-level meeting on non-communicable diseases relating to data systems in the cancer workforce? And how is the WHO working with partners to define priority indicators to monitor implementation of GICC? What are the roles of national cancer registrars and partners in improving collection of survival estimates? Dr. Ilabawi.
Thank you, Dr. Ira. So to begin, let us pause for a moment and appreciate what we've been able to achieve. This political declaration is a celebration of what our advocates, what our leaders in GICC have driven to put survival as a priority target for GICC and now for the NCD agenda. Comparing this declaration with the previous one, it is clear that governments are seeking for our community to move to more measurable targets and more accountability through data, research, and surveillance. But that's only the beginning. In order for us to have stronger cancer surveillance, we need to increase our engagement in work streams like Child GICR, a collaboration between IARC and St. Jude. This means increasing the volume and quality of reported data, and critically to empower registrars in ministries and in hospitals, those collecting and synthesizing data. Now let's take a deep dive on two key aspects of the resolution or the political declaration. First, this inclusion of the GICC survival target is a major achievement and win. It is a reflection of your efforts, and we thank you again for that, but it is only the beginning. If we successfully institutionalize survival as a priority target in the global and public health agenda, we can envision a world where we know whether any child survives a cancer diagnosis. And if survival is monitored, we'll then be able to strengthen systems and performance to ensure every child with cancer has an opportunity to receive the best possible care. And then one step further, childhood cancer survival should not only be part of this political declaration, it must now be part of every declaration in the post-SDG agenda. Together, we must keep pushing this forward. About workforce, it is a glaring gap. There is no prioritization of the cancer or NCD workforce in the political declaration, and thus no specific recommendations. When we look at the nature of the declaration, we see that there are aspects, medicines, technologies, those are the focus. And in many ways, we can celebrate that we are progressing in those realms, but we are leaving behind the skills gap that are needed to address all aspects of the GICC targets and, of course, the SDG agenda. We must now speak with one voice to say that without investing in people, we cannot invest in health. We must advocate for our workforce, for those that are in the trenches day and night, because they are the future of GICC and our ability to achieve the survival target. Now, what is it that we're doing at WHO to advance the collection of survival estimates and to help understand how they apply in a country context? We're very pleased to share that in the next year, we will have new data. Working with St. Jude, SIOP, and thank you to Dr. Chantala, IHME, Concord, we're producing the first global estimates in childhood cancer survival. This really will be a special moment. In February 2026, we will be releasing the results, and they are very informative and motivating. The process has been powerful to help mobilize governments to review their own data and to engage their own national registrars. So please be ready in February of next year when we release the Global Status Report on Cancer and a focus on GICC implementation. But of course, one estimate is not enough. We're also in the process of developing a comprehensive monitoring and evaluation strategy for the global initiative. This is part of a broader ambition at WHO to develop a global cancer monitoring framework, which is integrated for all WHO cancer initiatives and has a specific focus on childhood cancer. Our next step is now to work at the local levels to build capacity to monitor and report priority indicators, and we've already been able to do that working with governments to strengthen their cancer control plans with a monitoring and evaluation framework, working with dear colleagues like Dr. Lisa Stevens, who's in the audience as well. This is not the beginning. We know a lot of great work has already started with different partners. And of course, we have the unique opportunity of the Global Platform for Access to Childhood Cancer Medicines that's allowing us to get real-world granular data at the local level. We can only do this if we empower national stakeholders. More data used means better data produced in the future to create a new norm for national and global reporting of childhood cancer performance. One last critical point, which is cancer surveillance systems cannot be disconnected from people. It must be inclusive of all stakeholders, particularly those with lived experience. We must focus to children and parents affected by cancer, and they're the ones that should be driving the agenda forward. As I close, just a brief moment to say I'm so sorry that we cannot be there with you in person and are very happy that Dr. Liliana is there. Thank you to SIOP again, to Dr. Chapada and the team, to the Memorial Sloan Kettering Kids team, and supporting organizations, St. Jude, CCI, and Foundation S. As Carlos said so well, it's such a powerful moment. Many of us were together 7 years ago. Since then, we have become such a powerful village, and I'm humbled to be part of it. We are also so grateful to be partnering with many of you around the table. But not far from where I am right now abroad, there are children with cancer who are living in war and living in crisis. Let our community continue to be there for them, for all children, until each and every single child is given that chance to survive, and to thrive. Thank you again for the opportunity to join you, and really we look forward to our continued partnership ahead.
Thank you so much, Dr. Andre Alabi, for your powerful words, and we thank you that you were here, although online. We appreciate that. Thank you so much. And now we move on to our next panelist, who's Maite Gorostegui from San Juan de Dios Hospital, Barcelona, Spain. Maite is also our SIOP Global Mapping Committee Chair, and also she's the Medical Director of an education program, Teleo, in Latin America. Maite, what is the Global Mapping Program in SIOP? Can you just tell about it, that we're doing it in 6 continents and the parts that are already finished? And how has the Global Mapping Program helped identify gaps in the pediatric oncology workforce in Latin America?
Hi, hello to everyone. It's a privilege to be here with you and with this panel. I am a pediatric oncologist as well. The other activities are extra. Well, the SIOP Global Mapping Program exists since 2018, same year that the global initiative was launched. And the objectives that we are following are in completely alliance with you would see now. And what are we doing? We are mapping every facility treating children with cancer worldwide. We want to know where are these facilities, but also we want to know which resources do they have to treat the children. And one of these main focus is the workforce. If you think we, as pediatric oncologists and nurses working in oncology and the whole team, we belong to a workforce that is so complex. I am, as I said, a pediatric oncologist. I can have the chemotherapy, the knowledge, but if I don't have the hands to remove the tumors, my child will not survive. So if you look the data that are already published, we as a community, we had the feeling that we don't have enough to take decisions or to go to authorities. We don't have enough data about the workforce. And in Latin America, and also with the global mapping, obviously, we already have data that I will share with you, and this data are already being asked in other continents. We are collecting data from Asia. Africa was already completed. Oceania is in progress. And I hope we will share this data soon with you. But coming back to Latin America, the workforce. If I will start sharing about pediatric oncologists and the context. We were able to collect data from 20 countries. We invited more than 300 centers, and they reported 21,300 new patients per year. This is a representative sample. If you look, then you are expecting in Latin America circa 30,000 new cases per year. So it's a good sample, and we were able to point out things that we were expecting, that most of the patients are treated in public institutions, but there are something very, very interesting that 60% of the patients are treated in 70 institutions. So if you think if your politics go to these 70 institutions, it will have a big impact. If you look the data about pediatric oncologists, how many pediatric oncologists per new patient per year do we have in Latin America? In average, we have one pediatric oncologist for every 21 children. So you say this is not too bad. Ideally, we would like to have one every 15. But if you look these 70 critical centers, how are they working? There is one pediatric oncologist per 40 or 50 or even more new patients per year. So it's evidently that we need to help the workforce, and we need more pediatric oncologists in these centers. Then if you look the nurses, do the nurses have enough time to work in the ward where the children are, or do they need to move? So the reality is that they need to move. So 88% of the nurses are rotating. That means they cannot become expert in pediatric oncology, despite all the effort and all the training and all the initiatives. But this is the number. So 88% of the nurses need to rotate. What about the surgeons, the surgeons with expertise in pediatric oncology? Well, it's less than half. In the centers, if you look across all the centers, it's like 46% of the centers do have a pediatric surgeon that is an expert in pediatric oncology. And when maybe you have the question, okay, we want to increase this number, do we have the possibility to train these pediatric surgeons to become an expert in oncology? Only 3 countries have the possibility to train a pediatric surgeon to become an expert in oncology. So we have a lot to do. And the other numbers are better, and this is also I think to be proud. If you look the numbers of pharmacists, nutritionists, psychosocial support, we are up to 90% across all the centers. So this is something really, really good. And if you look something that is a necessity, palliative care, I can share that what we found was like the number was 25% are lacking this essential support, palliative care. But it's a number that we need to interpret as well, because when we look deeper, we noticed that this was most evident in centers that were small, not these 70 critical hospitals, and they they have palliative care. But I think this data that come from SIOP are really, really interesting and open a door to think about solutions and about other possibilities that can help the workforce is Teleo. Teleo is a program that is has the financial support by Foundation S, same thing, the Global Mapping Program. And Teleo is giving the opportunity to all fellowship in pediatric oncology Latin America, in Spanish and Portuguese, to strengthen the formation. They have a program that lasts 2 years, is independently of their own program in their countries, and they have their experts that every week are given a class, and they can exchange experience, share the different contexts that they have. I think it's a really, really a good tool to help the workforce in the region. Same thing for the nurses. They are the main users of the platform.
Thank you so much, Maite. And education is a very important goal of SIOP, and our members have always in the feedback said that education is very important. And SIOP, through the online sessions, the webinars that we give, through the networks, working groups throughout the year, is all continuing this education. We have also partnership with the International Pediatric Association for early diagnosis for pediatricians. And also we have the discipline groups, that is disease-specific learning portals for pediatric oncologists, and also on a different network like survivorship, epidemiology, they have webinars, and we are continuing the education year-long. And also in the Congress, we do it in person. And really, education is a very important aspect of our life in SIOP. Thank you so much, Maite. And now we will move on to one of the GICC focus diseases, and where multidisciplinary approach is very important. Ira?
Thank you, Regine. So our next panelist, Dr. David Abramson, is the Chief of Ophthalmic Oncology here at Memorial Sloan Kettering. Certainly one of the world's great experts regarding retinoblastoma. And from a personal note, one of my closest collaborators in the past 30 years. Dr. Abramson's been asked to address 2 questions. One, what are the key competencies that ophthalmologists need to effectively treat retinoblastoma? And 2, how can training programs be scaled to ensure multidisciplinary care in low and middle income countries? Thank you, David.
Thank you, Ira, and thank you especially to my friend Guillermo Chantada. I'm going to talk a little bit about retinoblastoma, and in some ways it's the poster child of health inequality in the world. Why do I say that? Last year, worldwide, more than 50% of the children diagnosed with retinoblastoma died on this planet. And here at Memorial Sloan Kettering, and those children, almost all of them lost one or both eyes of the survivors. Here at Memorial Sloan Kettering, at the same time, in the same planet, our survival rate is over 99%. 95% of the children retain their eye, and 90% have normal vision. And as a result of modern treatment, it looks as if they have no long-term consequences from the treatment. How can that be at the same time? But it isn't just a story of success of Memorial Sloan Kettering. This is a story of success throughout the United States and other countries. I can remember the first time I visited Argentina about 30 years ago, and the first time I visited Brazil, the majority of the children who had retinoblastoma were dying. That was 30 years ago. Now, survival in those countries is almost equal to what we are here at Memorial Sloan Kettering. And countries like India and China, which 15 years ago had the majority of children surviving, now have the now have the majority surviving. So this is something that we can all do together. It's not, these results are not a result of a new targeted molecule or a new treatment. It's a result of people working together. Now, retinoblastoma is a little unusual in the pediatric oncology world. It is not diagnosed by pediatricians. It is not diagnosed by pediatric oncologists. It's detected by a parent, almost always the mother, worldwide, and it's diagnosed by ophthalmologists. But even for ophthalmologists, retinoblastoma is rare. In the United States, once you finish training in ophthalmology, the chances are you will never see a retinoblastoma the rest of your life. Another unusual feature of retinoblastoma is we don't biopsy it. It's not safe to biopsy, unfortunately. So we diagnose it largely on the way it looks. But there are more than 30 conditions that simulate retinoblastoma, and much of my life is seeing those lesions and not making a mistake. But worldwide, there are centers where as many out of 1 out of 10 eyes removed, where the physician thinks it's retinoblastoma, the physician is wrong. I've removed more eyes than anybody in pediatric oncology and ophthalmic oncology, and haven't yet made that mistake. So it's doable. What do you need then from the ophthalmologist? Well, first you need to be able to examine these children under anesthesia. You cannot examine the retina, and you certainly can't treat it without exams under anesthesia. And the average child with retinoblastoma has 36 separate anesthesias. So you have to have a facility where you can efficiently see children under anesthesia without making it a big deal in the operating room. You need a lot of equipment. It needs to be in a dedicated space. Few places in the world and very few places in the United States have that. I'm blessed to have that. You need an ophthalmologist who is a surgeon, because we do a lot of surgery on these patients. You need someone who understands radiation, understands pediatric oncology, someone who's efficient with the laser. They have to have a laser. They have to have cryo equipment. We regularly now inject chemotherapy directly in the eye. It is extremely effective, thanks to Francis Meunier and his work in Switzerland. But you need to have the facilities, you need to have the ability to work with people in your own institution to do that. You need to communicate with colleagues. This is a real problem. I understand the world of ophthalmology very well, but I assure you, very few of you in this room know the vocabulary I know. But you know a vocabulary that we don't know. And in retinoblastoma, we need each other. We need pediatric oncologists. We need radiation oncologists, although less than we used to. We need interventional radiologists. We need nurses. We need pharmacists who can do our unusual intravitreal and intraarterial chemotherapy. And we don't speak the same language. So one of the things you have to do if you want to set up a center is put people in a room, people in your own institution who have probably never met each other, didn't even know that there was something called interventional radiology. And you need to teach them each the language so you can communicate. That's not so easy. And you need to include the nurses, because more than anything, what you say to the patient has to be exactly what your colleagues and what the nurses say to the patient. So we put people in the room, we learned each other's language, we put questions down, we practice answering questions so that everyone on our diverse team says the same answer to the same questions. That's very important. So in summary, you need an ophthalmologist who can do a lot of things, who can speak a lot of languages. The fact that we now have countries throughout the world where survival is high and children are living normal lives is a testament to the fact that we don't need a new targeted molecule. We don't need more research. We have figured out how to cure this disease with very few complications, and the entire world should be able to do it.
Thank you so much, Dr. Abramson. And as you know, retinoblastoma is one of the 6 GICC focus diseases, and we have to cure it worldwide, as you have said, with the multidisciplinary tumor boards, multidisciplinary speaking, and we need physicians, nurses, psychologists, and all other healthcare professionals and parents and survivors in all aspects of pediatric oncology to advance childhood cancer. Thank you so much. And now coming back to SIOP. SIOP is a community with diversity in age and geography and also in gender. Half of our members are from high-income countries and half are from low and middle-income countries. And almost a little more than half are women and the other are men. And also when you think of the age, we are young by heart, but when you think of metrics, the ones that are less than 40 years of age are called young SIOP. So 1/3 of our members are young SIOP, and we are very proud of that because they are the future. We will give the torch to them so that they can advance. And now we will have a representative of our young SIOP network, who is also the co-chair of the Research and Innovation Working Group in the Global Health Network. And our other co-chair is also here. Can you wave your hand, Kathleen? Good, yeah. So we have the young SIOP members here. Shushan, I would like to introduce Shushan. She is from Yerevan University, Armenia. And we would like to ask you about your insight. What are the major challenges young pediatric oncologists face in low middle income country? You are from low middle income country for professional development. And also, which training opportunities would be desirable for young pediatric oncologists in LMICs? And also, I would like to announce that she is getting the Rising Star Award in Amsterdam in the SIOP Congress next month in October.
Thank you so much. Hello, everyone. I'm Shushan and I'm coming from Armenia. And early career oncologists usually face a lot of challenges. There are very few structural fellowship programs in our countries and limited research opportunities. We have limited mentorship opportunities. And when we are saying that the access to diagnostic and treatment approaches is affecting only the patient care, but from the other side, it also affects the professional development of the physicians. And they are also having a lot of financial and logistical difficulties to attend the international conferences and conferences. And that is the places that we usually find our mentors, we engage with our peers, and with whom we probably in future we can start new research projects together. And in my recent analysis, I did a review of abstracts getting submitted to SIOP, and 84% of the abstracts that are getting submitted are not becoming manuscripts. So the half of them are coming from low middle income countries, and half of them are from young oncologists. So it means that the research that they are doing is remaining only on the paper. And so somehow young oncologists are becoming isolated in low middle income countries. And I know this personally. Armenia is a very small country. We have less than 3 million population, but I was incredibly fortunate to have the exceptional mentorship of Professor Gevorg Tamamian, who always taught us fellows that even if we have limited resources, even if we have a few number of patients, 100 cases per year, we should try to work on the research questions that are filling the gap not only locally but also globally. And in my first year of fellowship, in the first months, I applied to the program of European School of Oncology and SIOP, and I started my fellowship in Italy, and that was a completely different world, life-changing experience. I was seeing cases that I've never seen or just read in my university textbooks. And then I traveled a lot for my training and fellowships in Vienna, in URTC, and at Harvard. And what I realized from all that experiences is that education abroad is not a privilege. It should be essential part of our curriculum because that is the way that you learn, you exchange, and you get mentors, and you start working on research projects. And so on. And then SIOP came, and I got involved with the SIOP. And in my first year of fellowship, again, I was elected as the co-chair of Education and Training Working Group. And You know how it works. Actually, these opportunities give the confidence to the people you are thinking that even though I'm coming from a very small country, I can contribute to the global oncology community. And I deeply believe that every country, no matter its size or resources, they have huge potential. And if we work together, if we stand together, we can definitely unlock that potential. And I always like the quote of Nelson Mandela, who is saying that education is the most important weapon. And with that, we can change the world. And I truly wish that we only invest in this weapon. Thank you.
Thank you so much, Shushan. In SIOP, we have geographic diversity and we have 6 continental branches. And now Ira will invite our SIOP Africa president.
All right, our final panelist in this first part of the meeting is Dr. Joyce Kambugu from Kampala, Uganda. As Regine said, she is current president of the African SIOP Continental Branch. The questions that have been posed to Dr. Kambugu to address are, what are the most pressing challenges in implementing the GICC program in Africa? And can you share a success story that illustrates progress in workforce development or policy change?
Thank you very much for this opportunity to speak about Africa. Africa has almost 40% of the global burden of childhood cancer, and yet survival in many parts of Africa is less than 25%. And that's a big challenge for us. So as the leadership of SIOP on the continent, about 3 years ago, we asked ourselves that question already. What are the most pressing challenges of implementing the GICC in our continent so that we can make strides in achieving the target of 60% survival? And so those problems we thought we could address in our strategic plan. And I wanted to highlight 3 of those problems. One of them is policy inclusion. And here, the instrument of policy inclusion has been spoken about, and that's the National Cancer Control Plan. And a few years ago, only a handful of countries in Africa had a National Cancer Control Plan that even mentioned children. And here I've mentioned, I think, like 1 sentence or 3 sentences, a paragraph. So really tokenism. And so if we are not included in the National Cancer Control Plan, it means that the country has no plans for us. There's no activities, there's no budget, or just an invisible population. And that problem still persists even now, being excluded from policy. And if you are not included, then how are we going to implement the GICC initiatives at all? So that's a really big problem that is persisting. The second problem has already been spoken about, and it is so true, and that's the issue of data. In many African countries, childhood cancer is still an invisible data point. And population-based registries on the continent cover less than 5% of African children. So when we don't really know how many children are affected or what services they need, it becomes a problem, because without this data, how can you plan? How can you budget anything? How can you have accountability? You're really flying blind. You don't know where you are. And that's a big, big problem for us. And we need to have comprehensive childhood cancer registries. Dr. Elbago, you talked about this. And this should be integrated into health information systems and data packages to enable decision makers and frontline health workers to actually, do something. And Dr. Elbago, we spoke about the Concord 4 that's coming out, and it is really unfortunate that only a handful of countries in Africa actually contributed data to Concord 4. So once again, Africa is going to be silent about what is the real situation on survival on the continent. And that's really, really big for us. The third concern that we have is the issue of financing and workforce. Really, what we would like to have is inclusion in universal healthcare, to have universal healthcare coverage and inclusion in the national benefits package. And quite frankly, there's only one country in Africa that has achieved the Abuja Declaration of spending 15% of the national budget on health. And this transmits itself even into NCDs like cancer. So really, there's almost no inclusion at all. And therefore, treatment of cancer in our continent causes catastrophic financial toxicity. And this results into things like abandonment, which are one of the biggest barriers to the real purpose of the GICC. So on the issue of workforce, it has been spoken about. A recent publication earlier this year found that the whole of the continent has 236 pediatric oncologists. And that means that there is one pediatric oncologist for 1.7 million children. And in that very same publication, there's 17 countries that have no pediatric oncologist at all. And even though we have increasingly more training programs, in that publication, we had about 22 training programs, but the rate at which pediatric oncologists matriculate from these is still too low to help us make any meaningful impact. So these are some of the big challenges that we're trying to address in our strategic plan. Having said that, there is some success, and I wanted here to highlight the issue of policy inclusion. It's still a big barrier, but some strides have been taken with regard to policy inclusion. And here I want to thank Kath and her team because they've been instrumental through the ICAIA series in helping us as African countries to actually include children in policy. And in 2022, we had 22 African countries that had included children meaningfully in their national cancer control plan. And this has actually had impact. So we can see at least Ghana, it's the only country, but still it has included 4 out of the 6 GICC cancers in the national benefits package. And we're all trying to achieve that. If you look at Morocco in its national development plan included workforce training for frontline workers. And in 2 years alone, they were able to improve their 3-year survival from 68 to 72%. And in Uganda, where I come from, for the very first time in history, we have ring-fenced 8% of the consolidated budget for the cancer control plan for children, which is unprecedented. It's still really small, but it is better than nothing. So these examples show that when governments deliberately make space for children, the systems begin to shift. And now, of course, our biggest challenge is to make sure that once children are included, it's not tokenism. This is actually followed up by meaningful activities and budgeting. So the most pressing challenges, as I said earlier, in implementing the GICC in Africa are very clear. We have weak governance in the form of national cancer control planning that's meaningful. We have invisible data for children on our continent. And also we have inadequate financing and workforce. But the direction is also clear. We've seen what policy inclusion can achieve. Yeah, thank you.
Thank you so much, Joyce, for giving all the challenges from firsthand, what's happening in Africa and what we can do further. So with this, we want to thank all of our distinguished panelists that have provided their insights into this very important advancements in childhood cancer that we are all seeking for. We know that we have to have pediatric cancers in the national cancer policies. We have to have universal health coverage. We have to have the SIOP global mapping to know where the facilities are, where the infrastructure are. We have to work multidisciplinary in all aspects, like in retinoblastoma, in all other childhood cancers. We want the young SIOP people, the young pediatric oncologists to get good education and to give the torch to them also, and so that we can advance pediatric oncology worldwide. And this is not an utopia. For example, in Turkey, we have seen with universal health coverage, with having childhood cancer in our national cancer policies, with having national cancer registries, and Professor Tezer Kutluk was the former UICC president. He's with us. He has been coordinating the National Cancer Registry. We can achieve that. We can see that advancement. So we want this for all the world, that we can achieve the improvement in childhood cancer. Thank you very much to our moderator and also to our panelists and to all of the audience for the attention. And with this, we will continue with the second panel. Maya and Nikhil, we would like to invite you.
Thank you very much. So we come to the second panel, and we will first maybe introduce ourselves. So my name is Maya Beck-Popovic. I'm pediatric oncologist in Lausanne, Switzerland, here in the role as chair of the WHO SIOP NSA committee. A difficult role, being successor of Kathy Pritchard-Jones, who is a fantastic person. I will try to do my best. And the co-moderator.
Yes, thank you so much. So my name is Nikhil Bhakta. I'm a pediatric oncologist at St. Jude Children's Research Hospital, where I direct our regional program in Sub-Saharan Africa, as well as our health economics and epidemiology teams. And again, for both of us, thank you to the organizers, Dr. Kang, as well as Guillermo and Carlos and others, for inviting us for this session on driving equity through transformative approaches, global access to medicines, and SIOP research capacity program.
Thank you. So in this second panel, we will look how research advances results in childhood cancer, and with special focus on equity, on family perspectives, and then also discuss more in detail the global platform for access to childhood cancer medicine. And we will have a diverse, I think, presentation and discussion. And this brings me to our first panelist, which is who is Roberta Ortiz, online, unfortunately. Thank you very much, Roberta, for being here. Roberta is for being online with us. And Roberta is medical officer at the Department of Non-Communicable Diseases and Mental Health at the WHO headquarters in Geneva, Switzerland, and especially in charge of the Global Initiative for Childhood Cancer. So, Roberta, I would like to ask you from WHO's perspectives, what roles can professional societies play in supporting the GICC goals towards achieving the 2030 targets and equity in childhood cancer care? Please.
Thank you. Thank you so much, Amaya, for the very kind introduction. And I am really pleased to be joining you virtually, all dear fellow pediatric oncologists, mentors as well, and esteemed colleagues. And particularly, I want to thank us, the organizers, our SIOP partners, but also the MSK Global Cancer Program for this opportunity, and particularly as we celebrate this very relevant milestone during the UN General Assembly. As many of you know, currently 84 countries are actively engaged in the implementation of the Global Initiative for Childhood Cancer across 6 WHO regions. And these member states are being guided by the Curol framework in advancing the GICC target of increasing overall survival for children with cancer around the globe to at least 60% and also reducing suffering. So from WHO perspective, professional societies are essential partners in achieving this GICC target, particularly through the implementation of the Pillar R regimens optimized for the delivery of quality diagnostics and treatment services. Societies collaborate to strengthen also research networks, and promote data collection and analysis, ensuring that ethical principles guide practice. This is particularly relevant to WHO as professional societies can contribute significantly to strengthen the clinical trial ecosystem, ensuring equitable access to research and innovation in low and middle income countries. As well, through the implementation, as it was highlighted by my colleague Andre Ilbawi, through the implementation of the Pillar E, focusing mainly on monitoring and evaluation, it's relevant to be able to make significant changes in the way priority interventions are being advanced at a country level. Particularly, as I mentioned, through enhancing research capacity building, but also strengthening health information systems for data collection and analysis. And this has been particularly relevant for the progress of GICC in many low and middle income settings. Also, I want to highlight that professional societies can contribute to strengthen advocacy efforts, particularly amplifying the voices of the lived experience to make sure that childhood cancer programs are not only well-designed, but also feasible, equitable, and effective in improving survival and the quality of life for children affected with cancer.
Thank you very much, Roberta. This gives the setting for the next discussions to come. Thank you very much for your presentation. And I will let Nikhil introduce the next panelist.
Thank you so much. And I think all of our panelists, in truth, reading the introduction, they are all well known in their own right. But for Liliana Vasquez, who is a technical officer for childhood cancer at PAHO, the Pan American Health Association, and also the regional focal point for the Global Platform for Access to Childhood Cancer Medications. And in that role, she plays critical roles in helping us think about the policy implications as well as the technical implications for what we do at the platform. So Liliana, the questions that we have for you are, as the platform begins to plan for its next stage of expansion, how are regional balance and economic equity being prioritized? And how do you foresee this project impacting health systems? Together with, can you speak to the role that SIOP and PAHO as examples of regional coordination and capacity building have played? Really, as I've always said, there's so much happening in Latin America that I think other global regions could learn from. So could you help give us some things that we should all emulate from your success?
Well, thank you so much. First of all, thank you for the invitation to this wonderful panel. It's so wonderful to share experiences with so many dear colleagues and very interesting topics, and important to move forward on our goal and common goal of improving care of children and adolescents with cancer. So indeed, the Global Platform for Access to Childhood Cancer Medicines is a wonderful initiative led by St. Jude, by WHO, in collaboration with UNICEF and PAHO. Our main goal is to provide high quality medicines for children and adolescents from low middle income countries. In the region of the Americas, we were really happy to say that Ecuador was the first country that started implementation in 2023, and we celebrated the arrival of the medicines this year in February. It was really an exciting moment. And then in Salvador, as the second country that actually started implementation this year. So, but we will be many countries to continue this work regionally and also globally. And when we speak about expansion, it's very important to consider several factors that could combine what is the best fit, right? The need that could come from that it's relevant for the country, the potential impact that the platform will provide to the countries with this initiative, and also the capacity that the countries have already to support these type of projects, right? We need to speak about the burden of disease, the number of cases that are treated in the country. The burden of disease is very important, but also the readiness that the country could have in terms of capacity of equipment, of infrastructure. And one thing that is very important to me is also that we should provide also elements from countries that could have deliverables or products or specific interventions that have impact in the national level, supported by national policies, supported by national interventions and national cancer control plan or a legislation. So when we speak about regional balance, it's also very relevant because being a global platform, we need representation from the 6 WHO regions across these regions, and also the representations from countries that will, of course, will come from countries from lower middle income countries, upper middle income countries as well. And if we could have also data from the country regarding access, the quality, the availability of essential medicine. So all these factors are very important to be combined. And definitely PAHO, SLAUP have an important role in this platform. I'm always, and speaking also what Roberta was mentioning regarding the GICC, very proud of the work that we have done and that Latin America is doing regarding childhood cancer. I think it's always a valuable example of regional collaboration from decades of international collaboration with important partners at St. Jude and many others, and also learning that we have similar challenges. I think Joyce also mentioned very good examples from Africa, but also in Latin America. Also, Guillermo is has a very important role in that. To share the perspectives that we have in the region, because we share the language, we share the culture in many aspects, and also we can learn from each other, right? I think Latin America is always a region in which we could learn from each other. And in that regard, PAHO has a very specific role to move forward on national policies, on national legislations, and to bring everyone together. Our role is to catalyze, to promote, to gather people, to provide discussions and spaces for discussions for all the stakeholders, and of course with the help of many colleagues and partners. And we have two, I think, main strengths. That is that we have, despite being an international organization, we have very strong presence within the country with colleagues that are working very closely with the ministries of health, because we articulate with the ministries of health very closely as well. And also that we have learned over the past to build very strong public health projects that are very successful through agreements with the governments from decades. So I think this is something that PAHO WHO is very engaged with. And SLAUP, of course, is like a little bit of my heart, because as past president of SLAUP, we're working very closely on the platform. I think it's also an example to mention that SLAUP is the voice of SLAUP, as the Latin American branch of SIOP, is the voice of the pediatric oncologists, of the pediatric oncology community, all the professionals, right? So in the platform also we have had very important discussions, research studies regarding the access to essential medicines in the 20 countries that will be published very soon. The quality of the medicine from the perspective of the pediatric oncology provider. And also SLAUP is an important space for dissemination, for the training of human resources, for the support on the consensus of national protocols. So I think it's very important, the role that we all have in these discussions. And just an example, in Ecuador, being a low middle income country that has many challenges with highly fragmented health systems, and with sometimes we'll say a lack of visibility of childhood cancer as a public health problem, and also deficits in infrastructure in some aspects. In less than 2 years, the platform has produced an enormous impact into the clinical aspects, the possibility to have new protocols for the country, the inclusion of essential medicines to reach 100% of essential medicines in the national essential medicines list, to investments into the supply chain or cold chain management, to have a national policy in childhood cancer. That was something that we didn't see that before. and in many other aspects as well, and the proposal of a national childhood cancer law. So this was impossible before. There's like a before and an after that these initiatives definitely could bring to a country like Ecuador, but many other countries as well. And today we're celebrating as well in El Salvador, our second country, the signature of the letter of agreement with the government, between the government and the platform. So I think the most important part to me is to combine this articulation of actors, stakeholders that needs to be together, to have technical expertise, to bring the best people to work in these teams, and finally, and most importantly, to respect the governance, because it's very important to empower the ministries of health and the government to make these efforts sustainable. Thank you very much. Very impressive. Dr. Allen is professor and vice chair for pediatric research at Baylor College in Medicine, but also chair for the program and of advancing research capacity for pediatric cancer clinical trials in low and middle income countries, the PARC. So, Dr. Allen, you have several projects have already been now implemented. And what at the time point now are lessons observed, learned, and impact that you can share with us? And maybe also the second question, what are the perspectives in terms of sustainability in ensuring a long-term impact of these projects?
Great, and thank you so much for that question. It's really great to be part of this panel and part of this overall discussion. And I have to say with PARC specifically, so this is the Program to Advance Research Capacity. And I was in the good position to inherit this from Guillermo and Kathy Pritchard-Jones, who really, I think, had this brilliant concept to really make research a central part of SIOP. And I think that as it's developing, I think the importance of this is becoming even more clear. I'm reflecting when Carlos was saying, the children of the world are saying they need help, and it's our job to address that. We're thinking about, well, what's the point of research, right? We're talking about getting medicines, we're talking about educating workforce, we're talking about creating goals, and as all of these things are happening, how do we know we're doing what we want to do, right? I think if we frame research as the quest to learn from as much as possible from every patient and to do better with the next patient, that's really at the core of, I think, what we do in pediatric oncology, right? So even in high-income countries in the 1960s, everyone was dying from leukemia, everyone was dying from lymphoma, and all of those curves that we show when we sort of demonstrate the successes of pediatric oncology, came after iterative, coordinated research studies, publications, grants, investments in ethical research. All of these things have led to, at the last ASH meeting with blinatumomab, we get another 10% survival in leukemia. 10 years ago, we learned that rituximab gives us over 95% survival in Burkitt's lymphoma. And I think this has all come about from sort of the collaborative research community that we've developed. And we have a system now where people like Ira Dunkel, who leads the Pediatric Brain Tumor Consortium, who does really critical phase 1 and phase 2 studies for patients with the highest risk brain tumors, they get signals of success. Once they get those signals, that goes to the cooperative groups, and then that becomes standard of care. And so I think when we're thinking about, well, how do we think about research in countries with different resources or countries who are just getting started, right? I think it's the same thing, right? We don't have to relearn everything, but I think the culture of research is really quite critical for us to be able to create a network such that we, even if it's a patient that we're only going to see one rare histology of, well, we have colleagues from the same, from the similar experiences who can share those outcomes. We can treat patients in a coordinated way. We can learn and we can advance. And so I think that the brilliant part of PARC is that it sort of instills this, front and center in SIOP, and we ask the question to various regions, to countries, to say, okay, well, give us a proposal to say, what is it you need to do better quality research, or to create a research consortium such that we can learn together. And I think that experiment led to, it did a couple things that were great. I think grants are great catalysts to create collaboration, because it forces a group to write down a plan, to create a team, and then to execute that plan, and then to be held accountable for that. And so I think with the first round of grants, we were able to fund a group in the Middle East, a group in India, a group in South America, and a group in Africa. And I think the universal lesson was that research is really hard, right? And I think the idea of everyone wants to do the experiment, everyone wants to get their paper published, but to lay the groundwork of how do you collect high quality data, how do you get material transfer agreements, how do you lay the legal framework, that's really the part of research that's essential, but it's the thing that doesn't get funded. I think most conventional grants fund the project, fund the clinical trial, right? And so I think what's brilliant about Guillermo and Kathy's vision for this is we're really getting grants not for the end product, but really to kind of lay the foundation. And so I think the lessons learned are, number one, there's a huge need for support. We're just scratching the surface, but we're able to make a huge impact with a relatively modest investment, and we really have created and enforced, at least with the first round of funding, 4 continental collaborative groups. So I think really the importance of creating infrastructure as a first step before we ask our young SIOP awardees to, when they get their abstracts and they want to present them and get them published, we need to lay a foundation such that they can all become successful. And we're really looking at this experience with Park to say, well, after we gave this first round of 2-year grants, how did it go? What are the lessons learned, et cetera? We're actually systematically analyzing that in a formal way. So we'll be able to come back and say, is this the right, did we do it the right way? How can we invest money in a better way? Should it be completely organic? Should there be some top-down support? Those are the kinds of things that will come out of that initial analysis. But I'd say the big lesson is that it's hugely successful, and we really appreciate the support from Foundation S, Amazon, the Chung Family Foundation that's supported us, and also the vision from our leaders. And then your question about sustainability, I think that's another feature of the Park approach that's different from kind of one-off projects, right? We're investing in a system, and I think the idea is that we can kind of go horizontal and vertical, such that as we get into our second, third, fourth generations of investments, we can maybe have RFAs that will entice existing consortia to take on new members. We can have targeted grants that entice people from 2 different consortia to collaborate with each other for a global Burkitt's project or global ALL project, things like that. But then what of course is key is the workforce, right? So I think getting the young, I like the way we use 40 as young, so in our field, but let's get the early career people excited about research, get them to know each other, get them working together. And so again, the Chung Family Foundation has invested in us supporting people from the consortia, some young people from the consortia. I think we can really expand that. So I think this experiment it's beginning to make a global impact, again, with a relatively modest investment. To make it sustainable, to make the impact even greater, I think more logs on the fire. If we can get more industry partners, philanthropy partners, countries to co-invest, I think this is just the beginning. I think the Park experiment is going to come to define a huge part of the impact of SIOP moving forward. And it's really exciting to be part of it. I just want to thank Girish Chinnaswamy, my co-chair, and then many of us on the panel here who are part of the Park committee.
Thank you very much.
Thanks so much, Carl. So Alejandra Mendez is the Vice President at Childhood Cancer International, CCI, the parent organization that is, of course, also works closely with the GICC and then SIOP. So Ale, the question for you that we have is, it's been really exciting because I think you've heard multiple statements now from others about the importance of individuals and families and parents and survivors with lived experience and the role that they need to play, both advocacy as well, all the way to research. But we've also heard the cautionary tale from Joyce about tokenism. And, we write it into our policy documents, we write it into our professional societies, normative bodies, that we must include persons with lived experience in the work that we do. And I wondered if you could speak to you're the lessons learned or the best practices that we should be adopting, and most importantly, what that timing might look like. When should we be involving families in the work that we do?
Thank you for your question. So today I'm proud to be here representing the voice of people with lived experience. I'm honored to be the voice of parents, children, and families who have experienced childhood cancer in their lives. I want to thank SIOP Guillermo for your vision and wise decision of incorporating us in these discussions. Thank you, all the scientific community here. Your tireless efforts and outstanding medical achievements have saved so many lives. As a mother of a childhood cancer survivor, I can only be grateful for that. Because of your research and your knowledge, today we're close to reaching the 60% survival rate that GICC set for us. Thank you. Thank you for that. We want to support what you're doing. As people with lived experience, we don't want to be a barrier or hinder your efforts. On the contrary, we want to build bridges. We may not have scientific training, but our real life experience gives us a unique perspective that we believe can add a lot of value to this conversation. We've been there. We've seen our children in pain. We have slept by their side in the oncology ward. We left behind our previous lives to access the protocols you have identified for us. We cannot cure cancer, you can. Yet, we are the battleground where cancer can be defeated. With your strengths and ours united, we are also the ones who will carry the long-term effects of this journey. That's why we need to work together. Our expertise is different, very different. You learned in a classroom or in a lab from professors. We learn by the bed of a child in cancer treatment. We have lived the disease. And living this disease in a family brings a kind of wisdom that needs to be acknowledged and heard. Because childhood cancer is much more than a disease. It's a deeply personal journey that reshapes lives. The voice of people with lived experience are essential in shaping effective cancer control programs, research, and public policies. If we want patient-centered care, we must include people with lived experience in decision-making. We bring insight, urgency, and authenticity to the table. We ensure policies and research reflect real needs, not just statistics. We hold systems accountable. We can also drive public policy to push urgency and buzz-worthy coverage. Results of your research, become humanized when we speak about them. They become real, not just data. When we discuss your results in first person, we provide a lived narrative so that policymakers and decision makers see a real perspective, which can be very powerful if we want to see changes, right? People with lived experience can and should be involved at every stage of the research process, not just as participants or subjects of research, right? But as true partners, from defining the questions, shaping methods, interpreting results. So you are probably asking, like, how can people with lived experience be involved in medical research? 1, priority setting and study design, so that research reflects realities that matter and impact families. Co-shape study objectives and protocols, help design survey questions to ensure they reflect real experiences. Ensuring research reflects real needs, not only academic or industry interests. Reviewing protocols to check if procedures are realistic. For example, a parent suggesting a less invasive monitoring to reduce child stress. Suggesting outcomes that are meaningful for daily life, not just clinical measures. 2, ethics and governance. We can provide perspective on consent forms, risk-benefit balance, and participant protection, ensuring that they are understandable, culturally sensitive, and respect. Adapt study procedures to local communities, review and simplify materials, track whether families' involvement is meaningful, not just symbolic. 3, implementation and recruitment. We can act as liaisons between research and communities, provide feedback on logistics and communication strategies, We can be trained as peer researchers, interviewers, or facilitators in studies. 4, interpretation of results. People with lived experience add a unique value in interpreting findings, bringing our perspective to help contextualize the results. We may highlight nuances that researchers might miss. For example, a survivor explaining why certain side effects are underreported, right? 5, dissemination and finding. Co-presenting at conferences or workshops, humanizing research data or findings. Share results with local communities in ways that resonate culturally. Help identify unintended consequences and areas of improvement. So to conclude, to all my colleagues in this table, some best practices. Value experiential knowledge. Be open to incorporating other perspectives that can enrich the outcomes of your work. Acknowledge lived experience as a valuable type of expertise. Engage people with lived experience from the very beginning, rather than only during data collection. Ensure we influence study goals, not just implementation details. Take time to build genuine long-term relationships with us. Advocate for our voices to be heard in national and regional health planning. Treat us as partners, not just participants. Respect local knowledge and avoid parachute research. Build infrastructures that last beyond a single research project. Train us so we can continue advocacy after your study ends. Support us to transition into leadership roles and decision-making. Recognitions matters too, whether in co-authorships or acknowledgements in publications, conference invitations, or leadership roles. Partnership with local NGOs, survivor groups, and parent associations have proven to be powerful in building trust and ensuring that research reflects local realities. Build feedback loops. Families must see how their input shape the research and how findings return to their communities in usable ways. So in conclusion, involving us meaningfully through the entire research cycle makes studies more relevant, ethical, and impactful, ultimately improving care and outcomes for children and families worldwide.
Thank you very much. This very well expressed lived experience makes a nice link to our last panelist, Dr. Claire Wakefield, who is Director of Research at the Division of Quality of Life and Palliative Care at Stanford University, and also SIOP Continental President Oceania. And why I say it makes a nice link, because the question is, why is important that research also includes voices of young people with cancer and their families, and also whether you have an example to share with us to see what impact this brings.
Wonderful. Thank you for the invitation, and thank you, Alejandra, for sharing your story. You are the perfect introduction for me. Look, if we are aiming to truly improve childhood cancer outcomes, survival statistics and laboratory results are, of course, essential, but they can only take us so far, because they can't tell us, for example, whether families are coping through treatment, whether they're able to stay in treatment, whether children are thriving post-treatment, or even what matters most to families. And that's where research on lived experience really comes into the fore. And it's critical for us to therefore amplify family voices when we're thinking about what's important to research. We can do that quantitatively, so we can measure it. We can use tools such as PROMs and PREMs, so patient-reported outcome measures can tell us the levels of pain or fatigue or distress that families are facing. And patient experience measures are also critical, because they tell us their experience of the hospital system. So they can tell us whether families are feeling heard, respected, supported in the system. And we can use that critical data to compare services, to look at improvements over time, and to identify gaps where there are some. And although quantitative research is critical and it answers some questions, there are some questions that can't be answered by numbers. And I think that Alejandra identified that really well, because often they can't tell us the story behind the numbers. And that's where qualitative research is really critical. So qualitative research can tell us a bit about the context, the why, the social, the political, the cultural factors that might be driving outcomes in childhood cancer. And without those, we can sometimes invest a lot of money in a lot of interventions without knowing why they're not successful. So I think that sort of highlights why it's really critical that we include families and the lived experience in our research. I have a really exciting concrete example to share with you. And it's a beautiful example because it's a collaboration that's happened with many people in this room and even on this panel. That's the WHO Lived Experience of Cancer study. It's been led over the last couple of years by Drs. Julie Cayrol and Clarissa Schilstra, with incredible support from Dr. Ortiz online and Dr. Ilbawi, who was speaking before from WHO, and over 50 incredible advocates and survivors, parents, and researchers from around the world, including Alejandra, Liliana, many people in this room, which has been wonderful. This study is aiming to quantify and also find the why around the experience of cancer around the world. And it's unprecedented in scope. So we have recruited almost 4,000 participants already from 125 countries in 25 languages. And we are going through the data now, and it's really remarkable. Looking at it last night, I was kind of blown away by some of the statistics that are already coming out. For example, 1/3 of participants around the world said that they currently do not have the financial resources to meet the daily needs of their families. And that wasn't just in low-income countries. 45% of the participants said that their psychosocial needs were not met at the moment. So there's a vast need for additional support there. And we have data from not only patients during treatment, but also post-treatment and even from bereaved parents. And we see the need continuing well past the cancer treatment period. And so that's a really beautiful example, I think, of engagement with young people. One of our key coordinators is actually a young survivor herself, and we have engaged the community and got feedback from parent organisations, young people organisations around the world, hoping to ask the questions that really matter for patients. How that's changed policy and practice, that's happening right now. It's already kind of garnering concrete action. So we're really excited that the study is likely to be listed or highlighted in the Global Status of Cancer report next year at the WHO level. And that document is a roadmap for countries to, in the future, use to decide how they allocate their resources and the priorities that they allocate. And that voice of children, young people and their families will be there in that kind of global level guidance. We're using it at the regional level to create tailored policy documents so that people can know what the different needs are in different communities, in different regions in the world. And at the country level, for example, we were really honoured to be invited to Papua New Guinea in May. They have been an incredible recruiter for the study, and we were able to present the very first ever data on the lived experience of cancer to the Ministry of Health in Papua New Guinea. And they were really blown away by what's important to families, and were inspired to change the sorts of the provisions that they are giving families in order to meet their needs and help them to actually stay in therapy and complete treatment. So you can see there a direct link to potential improved survival. At Stanford, we're also really excited to be working with PAHO and WHO to establish a WHO collaborating centre, and we're using the data from this study to decide what's important to do next to change care for children with cancer and other serious illnesses around the world under the leadership of Dr. Justin Baker. So I think I've hopefully convinced you. Thank you for staying to the very end of this panel about why family voices are not just a nice to have add-on, but actually are critical to the conversation. They change the conversation and can actually change outcomes in a really significant way that potentially clinical trials alone can't.
Thank you so much, Claire, and thank you to all of the panelists for your presentations. We heard about 3 major initiatives from policy, practice, and research. But of course, the key inputs that we wanted to highlight, recognizing that it's important to have voices as well as important methodologies incorporated that sometimes are overlooked. And with that, I'm going to hand it back over to Guillermo and Bente to sign us out.
What a ride. So difficult to give the concluding remark words. This has been really, probably have maybe just one keyword that I already said, which is diversity of the points of view, diversity of the knowledge, the people that we're discussing today in the panelists, diversity from the places where they come from, diversities of the lived experience with cancer. And I'd like to say to Alejandra, the reason why we are here is because of you. We want to, it's the other way around as well, because you are here because of us, and all what we do is because of you, because we really want to cure your children or every children in the world. So this has been really a wonderful panel. I appreciate again the time, the knowledge that you shared with us and the world, and also thank again for Roberta and Andre for joining. We wish you were here with us today. And thanks again for inviting us to do this panel. And this is a great privilege that we have to have Bente Mikkelsen in the pediatric oncology field. Bente has been for how many years the chair of the NCD department at the WHO. It was 15 years or so, right? A little bit too much. So she's really instrumental. She knows exactly the way that he lived this experience inside the WHO. So now we are privileged that she is part of the St. Jude team in Geneva. So we have her whole time for pediatric oncology. So we'll be giving her final remarks. We are privileged to have her.
Thank you very much, Guillermo. And I have to say that listening to people with lived experience and really believe that that kind of co-creation is the way forward. This is something I always believed was the right thing to do, and just listening to this. So thank you, Guillermo, and thank you, SIOP, for really underscoring this. It is a huge privilege. I was in Geneva some years, and now Carlos wants me to return to Geneva. And I hope when the Geneva office is opening that you will feel that this is a home for all of you. I'm extremely honored to work with this community, and I think we should be so happy today. So I don't know if you have followed the political declaration and all the things that has been going on for many, many months, but I can disclose to those of you who hasn't sort of followed so tight that there is not a miracle that we have got the separate paragraph on childhood cancer in the political declaration. That is hard work from all of you, from the St. Jude Global Alliance, from SIOP, from all the civil society who has spoken to their member states, supported them in really pushing for this. And it was a true pleasure to see that through the full negotiation process, nothing changed. So for those who hasn't looked at it, it is actually setting a target, which you know from before, from GICC, that we need the survival rate to be above 60% at least, but also that we want to reduce the suffering from all children. So I think it is a day of celebration, even if the real approval hasn't happened yet. It will happen later on. But it has been unchanged. People are very happy. We were asked to speak as well during the panels in the UNGA. So, and this is only because of you. This is only because you have been able to prove that, as you said, Guillermo, in the beginning, it is almost like a revolution. And people get hope. They believe it is possible, not only 60, but probably 80, 90%. So I will be super happy to continue to work with all of you on this. And thank you very much for inviting us to this very, very rich meeting. So all the best to all.
Thank you very much again, Bente. Thank you, everyone. Let's have some time for relaxing, to keep on discussing and having a nice time together watching this beautiful evening in New York. Thank you very much once again.